Hi, and welcome to the Clinical Informatics Board Review course. This is Lecture 2A2, Applied Decision Support, and I'm your lecturer, Bimal Desai. Here's the core content we'll cover in this lecture. It's Section 2.1.3, Application of Clinical Decision Support. The bullet points here include types of decision support, including alerts, reminders, and prompts, who the users are of decision support, including clinicians and patients, and then finally, implementing, evaluating, and maintaining CDS tools. So I've broken this out into a number of topics, which you can read here. And here's the sequence that we'll cover them in. So let's begin with the definition of clinical decision support. In its most restrictive definition, clinical decision support is an electronic system that provides structured guidance based on patient-specific inputs. So this definition includes expert systems, conditional alerts, and other types of CDS. A slightly less restrictive definition is that it's any tool that reduces the cognitive burden of patient care in the electronic health record. By this definition, you could include even order sets or corollary orders. You could include data visualization techniques or even visual design standards as a form of decision support because it augments your ability to understand the data that's being represented, and it reduces your cognitive burden. And finally, the least restrictive definition is that not all decision support is electronic decision support. So paper checklists might count as a form of clinical decision support. So that's led some people to actually when they refer to electronic decision support, to call it CCDS, or computerized clinical decision support. Here's another formal definition. This is from the organization SCAMSI, which of historical interest is the precursor to AMIA, and they define it as an active knowledge system in which which uses two or more items of patient data to generate case-specific advice. So you have to have a mode of communicating the knowledge. You have to incorporate patient-specific information, specifically two or more items, and there has to be a reference knowledge base against which you're making the decision. And together, all those together comprise the clinical decision support intervention. This is an oldie but goodie. This is a JAMA 1999 paper, The User's Guide to the Medical Literature, and they define many functions of clinical decision support systems. These include alerting, reminding, critiquing, interpreting, predicting, diagnosing, assisting, and suggesting. And you should be able to think of examples of all of these in contemporary electronic health records. I've listed a number of examples here. One way to stratify clinical decision support systems is based on the target, and the target of the CDS intervention should be determined by the clinical and the workflow needs. So, for example, you might expect very different CDS tools if you're trying to improve efficiency versus if you're trying to promote screening and earlier detection for a disease, versus whether you're trying to promote the more accurate diagnosis of something or to suggest a treatment protocol, versus CDS interventions designed to prevent adverse outcomes, to promote follow-up management, or to reduce cost or increase convenience. Other key design considerations are the target audience. Which member of the healthcare team, or is this targeted to specifically patients and families? In fact, probably one of the more common CDS bottlenecks is that we think of physician providers as the only logical recipient of CDS, and I think that's a pretty limiting way of thinking. And ideally, we would consider who the right person is across the healthcare team, including patients and families. Another facet that we have control over is the level of control of the intervention itself. In other words, is this something that anticipates a user's action? Is it something that they can call on demand? Is it suppressible, meaning I can dismiss the alert? Is it a hard stop, meaning I can't continue my clinical work until I address the issue in the intervention? Is it interruptive or passive? All of these are things that we have some level of control over when we design CDS. We can also change the mode of delivery. So, for example, if you accept my broader definition, the sort of middle definition of CDS, maybe we're using a documentation template to collect data. Maybe we're simply suggesting something like an alternate diagnosis. Perhaps we're summarizing results in a way that makes it easier for people to review. For example, highlighting abnormal vital signs or showing spark lines, showing recent vital sign and lab trends. You can have interruptive reminders or passive reminders. You can simply provide additional information either on demand or passively. Maybe there's some forcing functions that allow you to correct errors. Maybe we can suggest an alternate plan of care. All these things are impacted or basically influence the mode of delivery of the CDS tool. We talk a lot about the degree of interruptiveness. Is this, again, on demand? For example, maybe within your order composers you have a link to the formulary that the user can click on as a quick reference material, but they're not required to. And then these two terms that you should be familiar with, modal and modeless, which comes from sort of web design and computer science, that a modeless alert or an inline or a background alert is one that allows you to continue your work and does not force you to change your mode of interaction with the computer. So, for example, maybe your electronic health record has a simple passive indicator on the toolbar that changes color when you have unread lab results. Or maybe there's a passive reminder that this patient has health maintenance reminders that need to be reviewed and acknowledged. In contrast, a modal alert forces the user to change their mode of interaction. In other words, I cannot interact with the screen in the background because there's a screen in the foreground, typically a pop-up alert or some sort of interruptive dialogue that requires my attention, and I either have to dismiss it or acknowledge it in order to get it to go away. So those are called modal alerts. The Leapfrog group recognizes specific categories of clinical decision support, and they're worth reviewing. They include things like alerts for therapeutic duplication, single and cumulative dose alerts, allergies and cross allergies, contraindicated routes of administration, drug, food, and so on and so forth. They also expand the list of contraindications and dose limits based on diagnosis, age, or weight, recent laboratory studies. So, for example, maybe you shouldn't dose an aminoglycoside in a patient who has a recently elevated creatinine. And then dose limits based on radiographic studies, such as recent IV contrast. I think my favorite category out of all of these is the one on the bottom left. They specifically call out a category called nuisance alerts. And arguably any one of these categories could become a nuisance if it's done improperly. So what does the literature tell us about what makes certain CDS interventions effective? To that, we go all the way back to 2003 in this JMA article by David Bates. The article is titled 10 Commandments for Effective Clinical Decision Support. It's definitely worth reading. It's very high yield. And not surprisingly, many of the findings from 2003 are still very valid today. So, number one, speed is everything. That users of modern computer systems expect sub-second latency. You cannot expect a user to click on a button and have the computer churn for more than a second, honestly, and expect them to wait for the result. The second commandment is that effective clinical decision support systems anticipate the needs of the user and deliver them in real time. For example, showing relevant labs when you're composing a medication order. The example of maybe in your order composer for the aminoglycoside, you should show the recent creatinine and highlight it if it's abnormal. And ideally, you'd also probably want to offer what the guidance is for alternate dosing in the case of renal insufficiency. The third commandment is that good CDS tools fit into the user's workflow. In other words, if you're asking a user to exit what their normal workflow is, to exit the tool or the system that they're using, to go to a completely different tool or a different system or a different computer terminal entirely, specifically to enact the CDS intervention, that's not as good as the ones that are at the point of care. Number 4, little things can make a big difference. I can't even express how important this is, and I think increasingly we're finding that this is the root cause of a lot of burnout, alert fatigue, and in many cases we honestly don't know how to make things as usable as possible. But usability matters a lot, and it is our responsibility to make it easy to do the right thing when we design clinical decision support systems. Number 5, physicians resist stopping, and I would actually argue that this goes far beyond physicians. This is any user of the electronic health record, and even patient portals. If you show somebody a piece of clinical decision support guidance, whether it's an alert, a reminder, or whatever, ideally you shouldn't stop them from continuing their work unless you can feel pretty certain about the alternative action you want them to take. Number 6, changing direction is easier than stopping. So in other words, let's say that we have good upstream usability practices such that we can guide the user to the right action in the first place, such that they never see the high dose alert because the order composer prevented that from happening, or they never see the cumulative dose alert or the contraindicated diagnosis alert because, once again, the system is designed in such a way to prevent them from making the mistake in the first place. Number 7, simple interventions work best. I remember there was an abstract done years ago by Jan Horsky at an AMIA conference where he showed that they were trying to understand why a specific pop-up alert was going ignored by most of their clinical staff. And in his analysis, he determined that it's because the pop-up dialogue was far too cumbersome. It was like 3 paragraphs of text and no one would take the time to read it all. And so if you have guidance for a user, you should make it terse, you should make it compact, and you should make it actionable. Number 8, ask for additional information only when you really need it. And the guidance from David Bates and his team was that the likelihood of success is inversely proportional to the number of extra data elements needed. Number 9, you should monitor the impact of your tools, get feedback, and respond. I think it's a good practice, for example, in order sets to embed the contact information of the owner of that order set so that suggestions for improvement can be acted upon promptly and escalated correctly. And number 10, probably a big challenge for many organizations to manage and maintain your knowledge-based systems. I think at many medical centers these days we have hundreds and hundreds of types of CDS interventions, hundreds of order sets, hundreds of dose guidance rules, and the maintenance of these, the upkeep, the constant updating of these can be a challenge. Another source of reference for what makes good clinical decision support was described by Jerry Osheroff and his colleagues, something he called the 5 rights of clinical decision support. And you've probably heard these, but basically our goal when we design an intervention is to provide the right information to the right person in the right format with the right channel at the right time. So the right information means, are we showing them accurate and trustworthy knowledge as part of the CDS intervention, or is the intervention based on good information? The right person, again, is, consider avoiding that physician bottleneck. Consider who the correct recipient of an alert should be. If you're doing universal screening for recent travel in an attempt to identify travel-acquired illnesses like Ebola or something like that, maybe that can be a step that's shown to the registration staff and not to the physician staff necessarily. The right format. This gets to the heart of how you actually implement the CDS tool itself. Was this built in such a way that it's easy to use, that it's comprehensible, and doesn't take too much time? And the right channel, which means basically what mode of decision support. Was this in your electronic health record? Is this done through a text page on their communication device? And then finally, at the right time, is this integrated so tightly with the workflow that you're not showing somebody an alert for something that took place the day before? One of the major limitations of clinical decision support systems has been in a lack of sort of comprehensive literature to evaluate the efficacy of this. And if you go back about 10 years ago, one of the major limitations was that most of the literature was not representative of sort of the direction or the trends in informatics. Specifically, the bulk of the literature, maybe it's more than 10 years, let's say 15 years, the bulk of the informatics evaluation literature at that time was from a handful of academic systems who had developed homegrown CPOE, provider order entry, or CDS tools. And typically these were inpatient focused with less of a focus on ambulatory workflows. So in that sense, they're not representative of sort of the contemporary era of electronic health records, where these days the vast majority of health systems and office practices have commercial electronic health records. We haven't grown these ourselves. And in that sense, the literature reflects user interfaces and usability metaphors that aren't necessarily what we see in the commercial systems. Also, historically, there have been a lot of methodological limitations. And to some degree, I think this still persists today. There were historically few randomized controlled trials evaluating CDS, though this has improved somewhat. They tend to look at process rather than outcome measures, and in the quality improvement lecture, I'll give you a lot more detail about what that means. But basically, it means that we're looking at sort of measures of whether a process is being adhered to, but not whether those adherence to those processes can actually improve patient outcomes. There was a lot of literature, especially around the 90s and 2000s, that looked at the performance of diagnostic systems or expert systems. So these were very specialized decision support algorithms that were meant, for example, to provide risk calculation for myocardial infarction, or to help guide the provider to the correct therapy or diagnosis for limited sets of conditions. And those are not representative of sort of decision support at large. So, for example, just because you could develop a clinical decision support system that might improve the management for, total knee replacement in orthopedics, that didn't mean necessarily that CDS was useful at improving management for all conditions. Additionally, there was historically insufficient qualitative research, and maybe this is a bias across all biomedical research, but because this is such a human endeavor, it was really the work of a lot of pioneering investigators in the early and mid-2000s, like Joan Ash and Dean Sittig and other investigators, who brought to the forefront the need to have qualitative research in electronic health record evaluation. And finally, there was insufficient human-computer interaction research. So there was this entire discipline within the computer sciences for HCI with a vast and robust literature, people who were usability experts, very little of which of that knowledge was being tapped and put to use for evaluation of CDS systems or electronic health records. I think that's changing as well. One of the later lectures is actually on human-computer interaction, and you'll see that there's been a lot of work recently on trying to understand what is it about good design that influences user behavior most effectively. In other words, how can I design a CDS intervention in a way that it's completely intuitive to the user what they're supposed to do with the minimum amount of data overload. And we still have some practical limitations even today. For one thing, simply the lift of implementing and maintaining and updating these large electronic health records is often hard enough. And most of us don't have extravagant resources that we can apply to our clinical decision support committees. So Even simple things like the ongoing evaluation of your CDS interventions, the care and feeding of your tool, the frequent updating and revision cycle for your CDS interventions, those become challenging. So what do we know about clinical decision support systems, specifically the computerized clinical decision support systems? Well, there was a fairly recent set of systematic reviews in 2011 in this journal called Implementation Science. They have an online free access model where you can actually see all 6 of these systematic reviews, and they broke them down into a bunch of different areas of CDS systems, including chronic disease management, acute care management, therapeutic drug monitoring and dosing, drug prescribing and management, diagnostic test ordering behavior, and finally, primary preventative care. So I'll go through basically the summary of each of these review articles, topic by topic. If we look at the first one, chronic disease management, they saw about 55 trials, and you can read through the details here, but they basically concluded that a small majority, just over half of the decision support systems, improved care processes in chronic disease management, and some improved patient health. And notice how that's worded. They showed that a little bit more than half improved process outcomes, and even fewer improved patient outcomes themselves. The second topic was acute care management, in which they looked at 35 trials. 63% showed an improved care process of care. These were the types of studies they looked at. It looked at med dosing assistance, management algorithms, guidelines, diagnostics assistance, and so on. And while 20 of them looked at patient outcomes, only 3 of those showed any improvement in those outcome measures. So again, the conclusion was that patient outcomes were far less likely to be evaluated and far less likely to show positive results. So this is a continuous theme. This is a recurring theme in the CDS literature, that we can improve the process, but not necessarily the patient outcome. The next topic was drug monitoring and dosing. Again, the conclusion from this was that studies were small and generally of modest quality, and the effects on patient outcomes were uncertain, with no convincing benefit in even the largest studies. At present, no firm recommendation for specific systems can be given. In drug prescribing and management, the conclusion was, out of the 65 studies they reviewed, that CCDSS's inconsistently improved process of care measures and seldomly improved patient outcomes. Lack of clear patient benefit and lack of data on harms and costs precludes a recommendation to adopt CDSS, computerized clinical decision support systems for drug therapy management. They looked at diagnostic test ordering. Out of the 35 studies they looked at, 4 out of 4 that were designed to reduce test ordering rates actually worked. But they infrequently reported on cost, user satisfaction, and workflow impacts. So they concluded here that some decision support systems can modify practitioner test ordering behavior, and that studies should describe in more detail potentially important factors such as the impact of the system design, the user interface, the impact on workflow, user satisfaction, cost, unintended consequences, and so on. And then the last one looked at preventive care. They looked at 41 randomized controlled trials. And here they had some limited recommendations that the evidence supports the effectiveness of CCDSS for screening and treatment of dyslipidemia in primary care, a very, very specific positive finding, with less consistent evidence for CCDSS in other areas, screening for cancer, mental health, vaccinations, and so on. So this is a challenge, I think, to all of us in the field, that we need to sort of step up our game a little bit. I think that when you look at these studies, in some, what they basically reveal is that we don't yet know the best way to use decision support systems. There are sort of glimmers of hope. Every institution has success stories. Most of us probably also have evidence that it's not working in many domains, and we don't know what always distinguishes the ones that work from the ones that don't. Although we suspect it has to do with this sort of workflow integration, the 5 rights, the 10 commandments, and so on. Ken Kawamoto, who's done a lot of work on interoperable clinical decision support systems, wrote this BMJ article in 2005, another systematic review that looked at that determined 4 specific predictors of improved practice. This was, and by the way, these should remind you of the 10 commandments and the 5 rights, that 1, we should provide CDS as part of the clinical workflow. 2, that we should provide recommendations, not just assessments. 3, that we should provide CDS at the time and location of the decision itself. And 4, the decision support should be computerized, not just a paper checklist. And the counterpoint to all this is that we are also aware of this new category of woes, this new category of errors called unintended consequences. And these were initially described also by the group from Oregon Health Science University, Emily Campbell, Dean Sittig, Joan Ash, and the rest of the team here, back in 2006. And they noted, this was from a qualitative study, they looked at the types of unintended consequences related to computerized provider order entry. And there's a lot in here. More and new work for clinicians, introduction of new workflow issues, never-ending system demands, the persistence of paper despite the intent to eliminate it, and so on. The nest in the middle there is emotions, which led to a separate paper by Joan Ash on what they called the feelings paper, the sort of negative emotions that these systems can engender. So the one unambiguous area where we know that we benefit from decision support, structured order entry, and so on is in medication prescribing. And so medication alerts and computer provider order entry are one of the few unambiguous areas where we know that CDS helps. And this was demonstrated by a number of papers by Renu Kaushal and colleagues in 2001 in JAMA and 2003 in the Archives of Internal Medicine that demonstrated that there was clear benefit in reducing prescribing errors through structured order entry. Now, what's less clear is that even when we reduce prescribing errors, we may not be able to prevent adverse drug events that reach the patient. And this was demonstrated in a number of journals. It's true for both adult and pediatric medicine. And you may be thinking, well, how is that possible? How is it that we can reduce the number of prescribing errors and not reduce the types of adverse drug events that reach patients? And part of that has to do with this sort of Venn diagram of medication errors that's shown on the right, where in the universe of medication errors shown in maroon, there's only a slim subset of them there's only a slim intersection between that circle and the universe of adverse drug events. So think about adverse drug events that can reach a patient. Many of them are not preventable. Things like idiosyncratic reactions to medications, like Stevens-Johnson syndrome after getting Bactrim. And the subset that are preventable fall into this area that does overlap with medication errors. And it may be the case that we're reducing the potential adverse drug events, the yellow circle, through these interventions, but we're not really able to reduce the preventable ones, or that we may be shrinking the universe of all medication errors, and because preventable adverse drug events are so uncommon, we're not seeing we're not showing any statistical power. We're not seeing the reduction in those preventable ADEs. You can think of this in your own work. If you've ever worked with drug-drug interaction alerts, consider for a relatively rare or uncommon drug combination with sort of modest risk of interaction, how many of those alerts would you have to show to prevent one potential adverse drug event or preventable adverse drug event? In other words, what's the number of alerts needed to treat or needed to prevent a specific outcome? And if the outcome of interest is rare enough, that your number needed to treat is going to be quite high. We've hinted at this topic before, but I just want to make the point that there is this distinction between process and outcome measures. And A process measure, again, means that you are able to influence the process of care delivery. For example, can I get patients or can I get providers to follow the steps of medication reconciliation correctly? Whereas the outcome is the actual clinical end result that I'm trying to impact. In other words, continuing the MedRec example, simply following the steps is different from doing it correctly. That I can get them to march through the steps and click all the right buttons, but that doesn't mean that they're actually performing the MedRec steps correctly. So there was this systematic review in 2005 in JAMA where they looked at a number of different clinical systems: diagnostic, reminders, disease management systems, and drug dosing and drug prescribing systems. They looked at 97 trials that were intended to change practitioner performance. 64% of these showed benefits. So, in the whole, more than half of these CDS interventions actually seem to do what they're supposed to do in terms of modifying provider performance. But patient outcomes were not demonstrated to be impacted. Only 52 of those 97 trials looked at patient outcomes. Most of them were insufficiently powered to see the effect. So that gets at the point that I made earlier, which is that if you're looking for a rare enough outcome, you need a sufficiently powered study, which means you have to have a large number of enrolled study participants in order to see the change in the outcome itself. Only 7 showed improvement in outcomes, and none showed improvement in mortality. And even when they looked at surrogate outcomes, they were not consistently improved. So, for example, if you look at a disease like diabetes, there's lots of terminal outcomes that you might want to look at, such as development of nephropathy or something like that. But even an intermediate or a surrogate outcome like glycosylated hemoglobin, the A1C level, were not consistently improved. So after all that good news about CDS systems, let's talk about some of the more technical issues that face the field. One of the big challenges we have is with regards to knowledge representation and sharing of decision support systems. And this has been sort of the holy grail of CDS for a long time. There is a shorthand notation for a specific type of CDS limitation that's often referred to as the curly braces problem. And I'll tell you what that's about. There are ongoing challenges with how to represent, consume, and share clinical guidelines. There's also been the emergence of commercial CDS repositories by third-party systems, which are intended to reduce the individual healthcare system's need to constantly maintain and update CDS repositories. And there's a lot of appeal to this. The challenge has been to get them to operate with the electronic health record in a way that's seamless. We are confronting head-on this issue of standards and definitions within CDS, and it's going to be ultimately the only way that we can actually share CDS content between organizations. And it actually opens up the opportunity for distributed clinical decision support systems. So the idea that you can create a CDS rule that lives in the cloud, and then other electronic health record systems and other healthcare systems can basically subscribe to it and run it in a distributed fashion. Nobody has to build anything locally. We all can just sort of tap into the fact that there's a universal recommendation that's accepted and adhered to by all. So let's look at the first one, the curly braces problem. This gets its name from a guideline modeling syntax known as the Arden syntax, which was used by a number of electronic health records. I'm not aware, there probably are contemporary electronic health records that use Arden syntax for composing rules, but I think most of the modern EHRs actually have sort of a rule editor or an environment where you can go in and build rules using if-then logic and things like that. But nevertheless, when Arden was first developed, there were useful and usable ways to actually represent clinical knowledge. It was a great way to represent these sorts of clinical practice guidelines. So imagine, for example, that we were trying to create an Arden syntax rule that would show the user an alert if the patient's systolic blood pressure was greater than 140. So somewhere in that rule, you'd have to first tell the computer system to go fetch the last systolic blood pressure. And that's what's implied by this routine here, systolic blood pressure, read last. and then there's some curly braces, and then where it says get systolic blood pressure, that's where your organization would insert the code for how to actually fetch the systolic blood pressure from their database, from their electronic health record, from their target system. And then down below, they defined that the threshold for systolic blood pressure is 140. What I left out of this abbreviated rule was the condition that would say, for example, if the last systolic blood pressure was greater than the threshold, then show some alert, but you can imagine that's down below. So what's the problem with this? Well, the problem is the curly braces and the content in that get systolic blood pressure area. And it's because there was no common access method. There was no way to share this Arden syntax rule such that it was completely portable. I could share the logic, but every target system would have to implement those methods differently. And that became a challenge. If your homegrown system fetched blood pressures and stored blood pressures differently than my homegrown system, then even though I could share with you my Arden syntax, it wasn't truly a portable clinical practice guideline. I still had to do a lot of last mile work to get this to work in my own system. One of the other challenges of guideline modeling is this notion of ambiguity or vagueness. And this, I think, plagued decision support for many years. And one of, I think, a useful framework for thinking about guideline ambiguity was proposed by Rick Schiffman out of Yale in 2005, this model of ambiguity and vagueness in clinical practice guideline and recommendations. So in the universe or the constellation of ambiguity or vagueness, Dr. Schiffman identified three different axes, the axis 1, axis 2, and axis 3, and they all represent different things. Axis 2, we're going to skip over for now, but basically that's the axis that represents lack of concrete recommendations overall. So for example, maybe there's insufficient scientific data. Maybe there are legitimate ethical and religious complexities that make the CPG more ambiguous. Maybe it's a legal gray area. For example, if we're talking about, like the adolescent right to privacy and how that impacts clinical practice guidelines for showing data to them and their parents. Maybe there's economic constraints that the correct thing to do or the recommendation is really not economically practical. So leaving that category aside, axis 1 and axis 3 are the ones we're going to focus on in the next slide. So axis 1 ambiguity deals with how the clinical practice guideline is actually written. And Dr. Schiffman described what he called syntactic ambiguity. So this is where the wording of the guideline is such that I can't really guess what the interpretation of this is, and I can't model this in a way that's computable. So let's say there's a phrase in there that says something like, if the patient has fever or rash and hypotension, then do something. There's a problem there. If I'm thinking strictly like a computer, those ors and ands, I need to know kind of the order of operations. I need to know where the parentheses go. Is it sufficient to have either A or B and C? Or is it sufficient to have A or the combination of B and C? So the parentheses matter and will completely change how you model this guideline in a computable format. Semantic ambiguity is where you basically have not provided enough detail for the guideline modeler, for the informaticist, to successfully make the recommendations. So for example, I will meet you at the bank at noon tomorrow. Well, that's great, but we have to both understand which bank you're talking about if you want that meeting to go successfully. And that's true for clinical practice guidelines as well. Further testing is recommended. Pragmatic ambiguity is one where there's actually conflicting recommendations. And believe it or not, this, there are examples of this in clinical guidelines where one portion of the guideline might say to do something and another portion of the guideline might say to do something different. Under specification is when you are using terminology that is not concrete enough to be modeled. So for example, if I say all children should be screened for lead exposure, which children am I talking about? Am I talking about infants, teenagers, adolescents? What age group do we specifically mean? Are we recommending this for a specific well-child visit or sick visit in a very specific time frame, or something else entirely? Another ambiguity is strength qualifiers. So when there's a hedge phrase like recommended as probably effective, I don't know whether that's a useful thing to show to the provider or not. So the strength of the recommendation, and you've probably seen that these are almost universally included in modern clinical practice guidelines, the sort of the strength of the evidence behind the recommendation. And having that information is useful because we might show only the highest tier of recommendations, and the ones that are sort of ambiguous or nice to haves, we could probably suppress or show in a passive way. Next, there's the use of passive voice as a form of ambiguity. So when it says, additional imaging should be performed, it would be useful to know who should perform it. Are you suggesting that it should be performed in the inpatient setting by the team that's caring for this patient? Should this be followed up by a specialist in the outpatient setting? Who is the target of this action, and therefore, who do I need to show this alert to? Axis 3, the other axis in this Schiffman paper, includes a few other types of ambiguities, including conditional ambiguity, where there may be an if-then statement, but it's missing enough precision for me to be able to translate it into a computable format. And an example of this is there's a phrase like, if the x-ray is not suggestive of pneumonia. Well, it would be useful to know what that means. Does that mean the absence of an infiltrate, the absence of an effusion or abscess? What if they have some mild evidence of inflammation, but not a true lobar pneumonia? Or what if it looks like it's more diffuse or interstitial? So not suggestive of pneumonia may be a little bit too vague to be able to act on. And then finally, there's this this action ambiguity, where it might say, if the patient continues to deteriorate, further evaluation is recommended. Well, what evaluation is being recommended? I can't simply show a pop-up alert to somebody that says, please evaluate further. So if your guideline, your clinical practice guideline, actually lacks many of these specifiers, or contains many of these types of ambiguities, it's going to be really challenging to try to translate that into an electronically consumable clinical practice guideline. And it's actually led many guideline agencies to consider and include informaticists on their panels. So, for example, I know that for many years, Rick Schiffman participated with the American Academy of Pediatrics on the development of many of their clinical practice guidelines, specifically to be sort of the voice in the back of the room or in the front of the room that called out when something was too imprecise, and suggested that it could not be modeled with an electronic clinical practice guideline. So ambiguity is sort of one of the many themes that might make a clinical practice guideline interpretable by a computer or not. And it gets at the heart of this, that in order for me to create a clinical practice guideline in a way, to represent a clinical practice guideline in an electronic health record or a CDS system, the guideline itself must first lend itself to computation. In other words, it has to be written in such a way that I can extract all those if-then rules and do something useful with them. In addition, the format of the representation, the guideline representation format, whether it's Arden syntax or some other thing, must allow for sufficient clinical expressivity. And for example, we need to be able to model temporal dependencies. We have a lot of clinical practice guidelines that require look back and look forward rules. If the patient has not received this medication in the prior 6 months and is not scheduled for a follow-up visit in the next 2 weeks, then do this. And if your CPG cannot represent temporal dependencies like that, then you're not going to be able to create a useful tool around that. It needs to be able to represent arbitrarily complex rules. One of my favorite examples of this is that in pediatrics, there are some really, really detailed and complicated rules around which infants should receive the Synagis vaccine, which is something that babies receive to reduce their risk of respiratory syncytial virus, or RSV. And it's not a simple if-then rule. There's so many inclusion-exclusion criteria, and there's so many sort of nested if-then structures that this is actually a fairly complex rule to build. Ideally, again, your representation format should include the ability to stratify recommendations by strength of evidence, because it may be that you want to show the highest tier of recommendations in an interruptive way and then the others in a more passive way. Or maybe you want to create the clinical decision support system such that only the most pressing reminders show up in sort of time-constrained settings. And so you know that the provider is taking action on the most important things. Finally, we need to be able to distinguish between imperative and optional actions. So is something recommended or required? Is this a hard stop, or is this something you can override? And we need to be able to program the decision support rule in a way that allows for that. The guideline itself ideally should be mapped to a standard vocabulary and semantics, so that when we're talking about something like a CBC, I can guarantee you that we're both talking about the same thing. Many of us have probably dealt with trying to clean up data from source systems where someone asks for a report or something looking at glucose levels, only to find that we're not including just serum glucose, but maybe some urine glucose levels or CSF glucose levels snuck in there. And that can all be avoided through the insistence upon standard vocabularies. Ideally, the guidelines should be interoperable. It would be so wonderful if I could simply zip up a clinical practice guideline and send it to my colleague at another hospital who can unzip it and install it on their electronic health record. And again, it would be nice if it's portable. And by the way, interoperability also refers to interoperability between different disparate vendors. So what work has been done to create these robust guideline modeling frameworks? There have been a lot of proposed guideline modeling frameworks, including Glyph, Protégé. I mentioned the Arden syntax, which back in 1990 was actually endorsed by HL7 and ANSI as a standard. GEM, which is an XML-based format and an ASTM standard for representing clinical practice guidelines, also developed by Rick Schiffman and his team at Yale. And then Sebastian. If you want to see a more detailed summary of all these guideline frameworks, you can see that at the bottom there. And what's interesting to me is that many of these things have sort of borrowed from their predecessors. If you look at this timeline from 1975 to the mid-2000s, you can see how Oncosin became Eon T-Helper, which led to the emergence of Glyph 2 and Glyph 3, and a little branch down to Eon 2 and so on. That these guideline modeling formats often share a lot in common. The fourth one down from the top, the GEM format, actually takes it was derived from a set of decision tables, simple kind of like Excel spreadsheets that show you what decisions to make in which sequence. The truth, I think, though, is that today the commercial electronic health vendors rely less and less on these and more in favor of their local rule building environments or decision support CDS building environments. I hinted at the fact that knowledge maintenance is a real challenge, that once you have a couple of hundred of order sets and lots of hundreds to thousands of dose guidance rules, this becomes a challenge. And imagine, for example, that you have any rules that rely on EHR-derived patient data as that's one of those key definitions, and that data element changes. The note template where it was captured is modified. The flow sheet row where it was captured gets deprecated. Whatever the issue is, suddenly your decision support system is impacted by that. And so there is this interdependency, and there's this strong need to make sure that you keep your CDS tools up to date. So the current recommendation is that organizations should have a regular, almost annual mechanism to review guideline authorship, to ensure the accuracy and the sort of up-to-datedness of clinical practice guidelines and other CDS tools. Also, we're expected to review the patterns of use, looking at sort of process measures and adherence to workflows, whether or not people are actually taking the right action in response to their alerts. There are many mechanisms these days, whether they're canned reports that come out of your electronic health record or locally derived tools, to look at things like override rates of alerts. Also, this is a great opportunity to partner with your safety teams to look at sentinel events and to see if, for example, there's more you can do within your electronic health record to prevent those. So, for example, if you have a mechanism to capture all of your prescribing errors and you have a mechanism to aggregate them, you might find that there's a pattern, for example, in the dosing of a specific antibiotic, and then use that to go back and inform the redesign of that order entry screen. All of this is a lot of work, and it's probably the biggest reason why we're heading towards an era where we want to see service-oriented architecture for what many have termed plug-and-play CDS systems. By the way, most of these knowledge maintenance recommendations come from a recent guideline from the ONC that I've linked to here, the Safety Assurance Factors for EHR Resilience, or the SAFER guidelines. And it's worth going through with your CDS teams the checklist that they propose for best practices to see if you have those systems in place or not. One of the more intriguing proposals for the CDS systems of the future is this idea of shareable CDS. And this is a schematic from an organization called OpenCDS. It's an initiative to try to figure out the architecture and the implementation for shared decision support. So the idea is maybe there's two different organizations, institution A and B, both of which have their local electronic health record and local patient data sources, both of whom have subscribed to a group of clinical decision support applications, and based on triggers can invoke them. And when they're invoked, they actually reach out to an external decision support service. Think of this as sort of a web-based service, a web service or some other application running in the cloud that can receive the patient-specific data as an inbound data source, and that can push back to the clinical decision support system recommendations or conclusions or some other payload of useful information. And that service can sort of run, and as long as the knowledge modules that they're dependent on are updated periodically by the maintainer of the guideline, institutions A and B hopefully don't have to change anything with their build. They can trust that the recommendation will always be up to date. So a very practical example of this might be something like travel screening. And imagine, for example, in this era of Zika outbreaks and Ebola and MERS and other sort of travel-acquired pathogens, how useful it would be if we could all subscribe to a web service that contain the recommendations for the returning traveler from, for example, the Centers for Disease Control, and how much time and effort it would save every institution in the country that is trying to implement traveler screening. If the CDC updates the list of countries that were included in something like the Ebola alert back in the day, that list, that change is instantly updated at the target systems across the country, and none of us would have had to sort of constantly update that list of countries to say, oh, well, now Mali is off the list, and therefore if you're a returning traveler from Mali, you don't have to show the alert for Ebola. Or you can imagine any number of scenarios where shareable decision support is more effective than our current system, where every single institution, every single healthcare organization is separately designing, building, maintaining, and validating all of these fairly redundant recommendation systems. So OpenCDS is intriguing in its own right, not just for that diagram, but also because in May 2011 it became an HL7 standard for a decision support service. It's built from the ground up using open source software tools. There's a very robust authoring environment. It's designed from the ground up to integrate with ICD-10, SNOMED, LOINC, RxNorm, all of which our other lecturers will cover in their topics as standard terminologies. And it's also designed to integrate with other types of CDS tools, such as the HL7 info button standard. At one of the recent AMIA national conferences that I attended, there was even talk about how to align this work with the new FHIR standard and the SMART platforms. So speaking of SMART on FHIR, many of us have probably heard this, and hopefully you know more about it. You know that it's more than just a set of buzzwords that have sort of captured the imagination of CDS implementers. This was first described in 2009 in a New England Journal of Medicine article by Zach Kohani and Ken Mandel. And the article is called "No Small Change for the Health Information Economy." And it suggested that electronic health records should be treated like an extensible platform. Imagine them almost to be like an iPhone, where you could go to an app store and download modular applications that did very useful things and that I could swap out. If I didn't like this specific mail client, I could download a different mail client. If I didn't like this calendaring app, I could download a different one. So they suggested four main themes for what the ideal extensible platform should do. First, they suggested that there should be liquidity of data, meaning that we need to be able to reduce the impediment to data transfer, make it easy for organizations to share patient data in a way that's useful for triggering decision support. Next, we needed to have substitutability of applications, modular, interoperable, just like an app store. Next, they should be built to open standards for both open and closed source developers. So they did not exclude the notion that there should be commercial apps, that maybe you had to purchase this CDS intervention. But they wanted the standards to be open so anyone could do it, whether they offered it as a free service or as a purchased service. And their long-term goal was to have an ecosystem of these apps with a free marketplace of ideas, almost like a meritocracy, where the best CDS systems for diagnosing and treating myocardial infarction would be used by hospitals, and the other ones would sort of float to the bottom. So they recognized that to do this, they needed to propose a platform. And in 2015, they released this paper, the SMART on FHIR, a standards-based interoperable apps platform for electronic health records. There was a lot of work that led up to that publication. They first proposed SMART in 2010. SMART is an acronym for Substitutable Medical Applications and Reusable Technologies. It's a very lovely backronym. And in the first generation of SMART, the representation of the payload, the actual CDS interface, was done in HTML with JavaScript. They would handle the authorization of transfer of clinical information using OAuth, which is an open standard. They envisioned using RDF, or Resource Description Framework, for maintenance of the metadata, so you knew what was in the app that you were downloading. And it was based on common terminologies like LOINC for clinical observations and RxNorm for medications. But they lacked a really good standard for sharing granular clinical data, like problem lists and things like that, or specific clinical concepts like the act of medication order entry. And so this initial stab at the SMART applications, what's now called SMART Classic, really did not gain much traction with EHR vendors. In 2011, the HL7 community was very concerned that this HL7 version 3 standard, which was an XML-based standard that was going to replace the version 2 pipe delimited standard, was not really gaining traction. It's a very complex model. It's not entirely intuitive how healthcare systems were supposed to use this. And it led a group to consider a different type of resource for health data transfer that became known as the Fast Healthcare Interoperability Resources, or FHIR, F-H-I-R. And FHIR is a very compact way to represent specific nuggets of clinical information, which we'll go into in more detail. By 2013, the SMART team took note of this FHIR standard, this emerging standard, and decided that this was the missing piece. This was the the standard that they were lacking to represent granular clinical data, and it became part. So they adopted FHIR as part of the SMART stack, and that's how we get the name SMART on FHIR. So how does FHIR overcome this problem with how to represent granular clinical data? Well, the way they do it is by representing clinical data as what are called resources. There's a whole list of FHIR resources. There's resources for medication administration events. There's resources for things like allergies. All these things are represented in a very, very precise way. And if you click the link that's on this slide, you can actually get to the list of current resources that are supported by FHIR. One of the critiques of FHIR is that there's not a resource for every type of clinical data that you might want to use in a CDS rule, and therefore you're a little bit limited as of today with regards to like what kind of CDS rules you can do simply by transmitting FHIR messages. But be that as it may, if you're looking at a specific resource like medication, you can see in this UML diagram, which by the way we'll talk about in a subsequent lecture, that this is basically a multi-dimensional array, that a medication resource is defined by a SNOMED CT term. That's where it says code. It can contain reference to a manufacturer, which is that third line under the word medication. It can have 0 or 1 products. It can have 0 or 1 packaging formats. And it can have 0, 1, or many ingredients. Can come in 0, 1, or many different types of batches. And so on and so forth. And you can see how these are all related. So those one-to-many relationships is what makes this sort of multi-dimensional, that you have these sort of nested arrays of data or nested data structures. And while this looks complicated, if I'm a web developer or a computer programmer, I know exactly how to take this and put it into some useful format. In fact, on the FHIR resource list website, if you click any of these resources, you can switch it from UML view to a different view, such as something called JavaScript Object Notation or XML, which are very common web standards for transporting data back and forth. So here's an example of a FHIR resource. And this is the same resource, the medication resource, but now I'm showing it as a JavaScript object notation JSON template. So that nested array of concepts can be referenced with this, what is it, like 20 lines of code. And this, when you take a multidimensional structure like that and you put it into a set of nested, bracketed contents like this, that's called serializing an object. That means I'm taking this tree structure, but I'm putting it back into a linear line-by-line representation. So the computer knows exactly how to take this JSON structure, this serialized software object, and turn it back into a multidimensional array. So this is a very useful way to transport the sort of rich data that we need for clinical decision support. FHIR also then allows users to develop what are called RESTful applications. This is a design paradigm in software design. REST stands for Representational State Transfer, and basically it allows developers to simply use the 4 common HTTP methods, put, get, post, and delete, to perform essentially database functions. That when I do a put request to a website somewhere in the URL, that basically creates a data element. And when I say get, I'm reading the element. When I use the post method, that's like updating it, and delete is to delete. Another analogy that we need to draw is that if you look at this JSON template, and if you think about what this represents in object-oriented programming, which will be covered in the programming lecture, you can think of this almost as what's called a class diagram. This represents the class of medications. That is, this is a generic blueprint for any medication in the FHIR standard. And in contrast to that class description, If I want to represent a specific medication, now I'm creating a member of the class, or I'm instantiating a member of the class. And this pale green resource here, the medication resource, is a specific medication, and you should toggle back and forth between this slide and the previous slide and prove to yourself that this is in the same format as the previous slide, except that that one contains sort of a generic class description, a blueprint, if you will, and this one contains the actual populated data that refers to a specific medication. So if you look about midway down the screen, you can see that there's a reference to the coding system, and the code here is 400352007. I can see, in fact, that the code system that this FHIR resource is referencing is SNOMED CT. And if you go to the SNOMED website and actually look this up, you can see that this resource unambiguously refers to a very specific dose form of paclitaxel. It's actually the paclitaxel 6 milligram per milliliter injection solution that comes in a 5 milliliter vial. And a little bit later, under the form section, there's another code, also SNOMED CT code, that refers to code 440132002. And if you look that up on the SNOMED website, you can see that that unambiguously refers to parenteral dosage form. So this is an extraordinary amount of detail. If I'm a developer and I'm trying to build a system that's meant to verify the patient's medication list, and perhaps show useful information about that medication, I probably need to know which dose form the patient received and what the route of administration is. So this is a great example of why the reliance on standards is what's going to make these shareable decision support systems eventually interoperable. And here's an example of a non-trivial application that was built using FHIR. This is an app called the Pillbox by Duke University, and it basically, what the Smart on FHIR app actually does is that it fetches the patient's medication list, it looks up all of those SNOMED CT codes, and then it renders the medication list in a useful, very visual format like this for the patient to refer to. So, for example, I can see that in the morning, this patient is supposed to get lisinopril and donazepam, and I think it even has the dose form, 1 tablet. At noon, there's a separate list of medications. In the evening, there's a separate list, and so on and so forth. And this is meant to be basically an application that educates patients about their medication dosing schedule for the day. So what did it take to build this? Well, it took the FHIR resources for medication. It took the fact that this was transmitted back and forth between the electronic health record and the smart website, whatever web server is running the smart application in XML and JSON. It took the web developer who built the smart app some knowledge of what a RESTful API does and creating that API so that the electronic health record could hook into it. Smart itself had to provide the authorization framework. Now the most recent versions are using OAuth 2, a way to authenticate and to prove to the application that the host system is who they said they were and vice versa, using OpenID Connect. And ultimately, the EHR vendors also need to figure out a way to integrate this web-based interface into their user interface. So a lot of work just to show a medication list. And so when people talk about, well, why can't you just show a nice, pretty list of patient medications with the pictures of the tablets next to them in my electronic health record so my patients can see it? Well, this is the reason why it's non-trivial, is because you need this enormous foundation of standards and interoperability and web services and common standards for program development for this to actually work. But now we're almost there. So while Smart on FHIR provides a mechanism for sort of passive access to decision support tools, the provider can actually launch the application and upload the patient's medication list into that Pillbox application. Another category of decision support tools are the ones that are all triggered, meaning I do something and without me asking, the system actually anticipates that I might need some other information, and based on what I just did, triggers a new CDS intervention. This is very common in, for example, medication entry. And the complexity here is that in order for that to work, you almost need like a listener. You need some portion of your electronic health record that's constantly waiting for one of any number of triggered events. And when something does trip the switch, it then has to know to go out to a CDS service and retrieve it. So another recent effort to share and make CDS interventions interoperable is this CDS Hooks initiative. Again, this is also an extension of the SMART project, and it specifies how electronic health records should trigger or can basically trigger or invoke external CDS based on specific triggers, like, I've ordered a medication, check the med list for allergies or something like that. It's not quite yet a standard, but it does address a major barrier that we face to these computable, shareable decision support rules. And in this diagram, you can see, for example, that in step 1, someone orders Toprol XL 50 milligrams daily. And the fact that you've ordered a medication triggers one of these hooks. And the hook knows, okay, well, listen, the relevant cards here are pieces of information I want to show to the provider. So first I want to show them what the patient's expected copay is based on an information card. And these are basically things that might show up as notifications, or they use this card metaphor where you can sort of swipe to dismiss them. A suggestion card saying, for example, that maybe you should try a thiazide as a first line instead of this Toprol. And maybe an app link card where maybe it knows that there's a smart app that I want to launch to be able to explore this topic of managing hypertension in more detail. And then the user can read it, can run the app, can acknowledge the information, and then decide. Perhaps there's a completely closed loop version of this in step 4, where the CDS actually makes the decision to delete something, create something using those RESTful APIs. So this is sort of the direction that all this is going in the long term. And it's an exciting time to be in informatics, especially if you're involved in CDS work. So how do you deal with a problem like alert fatigue? This is a huge challenge for our field, and I don't think we have necessarily the best answers for practitioners just yet. But alert fatigue refers to the state of user resistance to guidance that's provided by an alert, even those alerts that might offer possible benefit or that might reduce harm, presumably because they're overwhelmed by unimportant alerts. And I say presumably because our best attempts to reduce those unimportant alerts have not always demonstrated a reduction in alert fatigue. But we think that has something to do with it, that low precision, unimportant, useless alerts is what caused this in the first place. One of the challenges if you're an alert fatigue expert in studying some of this stuff is that it's actually a little bit difficult to measure. We often use proxy measures for what constitutes a low utility alert. So for example, most of the literature on alert fatigue looks at override rates. But if you think about it, just because someone overrode something doesn't mean that it's low utility. There may be perfectly legitimate alerts that are constantly overridden because of the way they're designed. We also note that many EHR systems offer different alert designs for common types of alerts, like drug-drug interactions versus custom CDS rules versus other types of alerts. And so when you look at things like override rates or alert fatigue or adherence to CDS rules, you may actually be comparing apples and oranges, and what works in one type of alert may not be applicable to another type. It's also been difficult to define. So let's say that your goal is to reduce override rates. Well, what is an appropriate override rate, and what should it be? I don't think we actually know the answer to that. And finally, as I hinted, you have these counterintuitive results where even dramatically reducing the alert burden does not dramatically reduce the override rate in many cases. And in fact, one of the more sobering statistics has been that the EHR override rates have remained flat or perhaps even increased in the past decade. So here's an example from a 2016 article in JAMIA that shows the magnitude of this problem. Looking at different types of drug allergy interactions and the alerts that they trigger. that even in the scenario where you have a potentially life-threatening alert that's being shown to a patient because of a known demonstrated interaction or allergy, you're still seeing override rates of like 84% in this study. And between 2004 and 2013, this institution saw an increase in their override rates from 83.3% to 87.6%. Tom Payne from the University of Washington and one of our co-lecturers actually wrote this article on drug interaction alert override rates in the meaningful use era. And Tom did a lit search and went back through the literature to look at all the published papers that had reference to an override rate. And what he found was that unfortunately in the past decade or so, there's literally been no change in the published override rates. They're still in the high 80s, 90s rate, which again means that even though we think we have an idea what causes alert fatigue, we really don't have a good sense of how to address it. So because I don't want to leave you on a down note, I already did that with the systematic reviews of CDS. But here are some of the recommendations that I think that are actually actionable with regards to alert fatigue. First is that we should classify alerts into 3 levels. This is a relatively straightforward recommendation that if you look at all your drug-drug interaction alerts or something like that, make sure you can classify them as either mild, moderate, or severe. Second, you should develop a core set of critical drug-drug interactions. And there are published lists out there of kind of like the 15 most important drug-drug interaction alerts for adult medicine. There's even one for pediatrics that was developed a few years ago. Next, you should classify your alerts into active and passive and only make your critical alerts active or interruptive. And this should, again, harken back to all of what we've talked about in this lecture, that you can afford to be more interruptive if you're more sure what the correct course of action should be. But you shouldn't interrupt somebody for just an FYI. Number 4, you should conduct training on new improvements. If you suddenly get rid of a lot of nuisance alerts, but you don't tell your users, they may not even notice it, and they may continue to be fatigued or act as if they're in a state of alert fatigue. And then number 5, develop systems with automated feedback and learning to identify and to be able to dynamically move alerts from active and interruptive to passive and non-interruptive. One of the intriguing ideas in this area is that maybe we should let users suppress certain types of drug-drug interaction alerts, and actually some of the commercial electronic health record vendors support this. And with that, you have to sort of accept the risk that they might be suppressing a very useful alert. Alternately, you could come up with a mechanism where your clinical decision support committee periodically reviews the highest overridden alerts and decides whether or not to maintain them in the system, to change them, or to remove them entirely. So thanks for your time. That's the end of this lecture. And there's a list of supplemental reading at the end that I'll leave for you to review. Here's all the papers that we cited in this talk, including the Rick Schiffman papers on ambiguity and vagueness. Here's the papers about Smart on Fire and the experience of seeing rising drug allergy alert overrides in the electronic health record. There's the paper there about drug interaction alert override rates in the meaningful use era, written by Tom Payne. And that last set of recommendations came from this paper, Improving Utilization of Clinical Decision Support Systems by Reducing Alert Fatigue, Strategies and Recommendations by Studies in Health Technology Information. Here's some additional supplemental reading on lists of recommended DDIs that should be non-interruptive in order to reduce alert fatigue, as well as a list of high-priority DDIs to use in electronic health records for the adult literature, and then the one at the bottom is the one for pediatrics. A lot of useful references here, including the qualitative paper by Emily Campbell on types of unintended consequences related to CPOE. Here's the link to those 6 implementation science series alerts, the systematic reviews of the 6 different types of CDS systems. And here's finally some references for guideline modeling if you're interested in that topic. Thanks a lot.